Question 1. A patient is seen for follow-up after a successful appendectomy performed 2 months ago. The patient has no current complaints related to the surgery. What ICD-10-CM code is appropriate for this visit? A. K35.80, acute appendicitis without perforation or generalized peritonitis. B. Z09, follow-up examination after treatment for conditions other than malignant neoplasm. C. Z47.89, other orthopedic aftercare. D. Z51.89, encounter for other specified aftercare. Answer: B. Z09, follow-up examination after treatment for conditions other than malignant neoplasm. This question tests your understanding of follow-up visit coding in ICD-10-CM. The key phrase is follow-up after a successful appendectomy with no current complaints, indicating the patient is not receiving active treatment or dealing with a complication, but simply being monitored after the condition has been treated. Code Z09 is specifically used for follow-up exams when the original condition is no longer present and the patient is not receiving treatment for it. For example, a patient seen for a routine checkup after pneumonia has resolved would also be coded with Z09. Remember, Z codes describe reasons for encounter, and Z09 signifies a checkup after a successfully treated non-cancerous condition. Question 2. A 55-year-old male presents with chest pain. The physician performs a detailed history, detailed examination, and low-complexity medical decision-making, MDM. The physician orders an ECG and chest X-ray during the visit. What E/M code level is supported based on the documentation? A. 99,203. B. 99,204. C. 99,213. D. 99,214. Answer: C. 99213. This question requires applying the E/M coding rules for office visits. The patient is an established patient, presents with chest pain implies they are not a new patient unless stated otherwise, and established patient codes start with 9921X, eliminating options 99203 and 99,204 which are for new patients. For established patients using the 1995/1997 guidelines, you need to meet at least 2 out of 3 key components: history, exam, and MDM. The documentation supports a detailed history, detailed examination, and low-complexity MDM, meeting the requirements for a 99213, which requires at least 2 of the following: detailed history, detailed exam, low MDM. Always carefully read the patient's status, new versus established, and the level of each documented component to select the correct E/M code. Question 3. A surgeon performs an open reduction with internal fixation of a fractured right tibia. Which CPT modifier should be appended to the surgical code to indicate the laterality? A. RT. B. LT. C. -50. D. -78. Answer: A. RT. This question tests your knowledge of CPT modifiers for laterality. The description specifies a fracture of the right tibia, indicating the procedure was performed on the right side of the body. Modifier RT is specifically used to designate procedures performed on the right side. Modifier LT would be for the left side, -50 is for bilateral procedures, same procedure on both sides, and -78 is for an unplanned return to the operating room for a related procedure during the postoperative period. Always look for keywords like right, left, or bilateral in procedure descriptions to determine if a laterality modifier is necessary. Question 4. A patient undergoes a magnetic resonance imaging, MRI, of the brain without contrast, followed by MRI of the brain with contrast. How should these services be coded? A. Code for MRI with contrast only. B. Code for MRI without contrast, and code for MRI with contrast, applying modifier 59 to the second code. C. Code for MRI without contrast, and code for MRI with contrast. D. Code for MRI without contrast, and code for MRI with contrast, applying modifier 51 to the second code. Answer: C. Code for MRI without contrast, and code for MRI with contrast. This question addresses coding for imaging studies performed with and without contrast. CPT guidelines specify that when the same imaging study is performed first without contrast and then with contrast, both codes should be reported separately. There is no need for a modifier like -59, distinct procedural service, or -51, multiple procedures, because the CPT manual structure and guidelines for these specific imaging codes already account for this scenario. Think of it as two distinct phases of the same study, each requiring its own code. Question 5. A patient is diagnosed with squamous cell carcinoma of the skin of the left arm. Which ICD-10-CM code category should you begin your search in the alphabetic index? A. Neoplasm. B. Carcinoma. C. Malignant. D. Skin. Answer: A. Neoplasm. This question helps you understand the correct starting point in the ICD-10-CM alphabetic index for conditions involving cancerous growths. While carcinoma, malignant, and skin are relevant terms, the primary term for any cancerous tumor in the alphabetic index is neoplasm. Under neoplasm, you will then find listings by anatomical site and the specific type of neoplasm, example squamous cell carcinoma. Always start with the pathological type or the main condition, like neoplasm, when looking up diagnoses in the alphabetic index. Question 6. A patient presents for removal of a foreign body from the external auditory canal. The physician uses an operating microscope during the procedure. What CPT code is appropriate for this service? A. 69200. B. 69205. C. 69210. D. 69220. Answer: B. 69205. This question tests your ability to select the correct CPT code based on the procedure performed and the method used. The key phrase is removal of a foreign body from the external auditory canal and the use of an operating microscope. CPT code 69205 specifically describes the removal of a foreign body from the external auditory canal requiring general anesthesia, but the code description notes it is also used when requiring use of an operating microscope, even without general anesthesia. Code 69200 is for removal without requiring general anesthesia or microscope, 69210 is for impacted cerumen, ear wax, and 69220 is for debridement of mastoid cavity. Pay close attention to details like the instrument used or the type of anesthesia when selecting procedure codes. Question 7. A 45-year-old male is diagnosed with uncontrolled essential hypertension with stage 3 chronic kidney disease. What are the correct ICD-10-CM codes for this patient's conditions? A. I-10, N18.3. B. I-12.9, N18.3. C. I-10, N18.9. D. I-12.0, N18.3. Answer: B. I-12.9, N18.3. This question requires applying the coding guidelines for hypertension with chronic kidney disease, CKD. When hypertension and CKD are present, ICD-10-CM assumes a causal relationship unless the provider states otherwise, and specific combination codes exist. The alphabetic index directs you from hypertension, kidney, with chronic kidney disease to category I-12-. Within I-12, you select the fourth character based on the stage of CKD. Stage 3 CKD is N18.3, and uncontrolled essential hypertension with CKD stage 3 is coded with I12.9, hypertensive chronic kidney disease with stage 1 through stage 4 chronic kidney disease, followed by N18.3. Always consult the ICD-10-CM guidelines for combination codes, especially for conditions frequently linked like hypertension and CKD. Question 8. A patient is seen for evaluation and management of a dislocated shoulder. The physician performs reduction of the dislocation in the office. How should the E/M visit and the reduction procedure be coded? A. Report only the reduction procedure code. B. Report the E/M code and the reduction procedure code. C. Report the E/M code with modifier 25 and the reduction procedure code. D. Report the reduction procedure code with modifier 59. Answer: C. Report the E/M code with modifier 25 and the reduction procedure code. This question tests the application of modifier 25. Modifier 25, significant, separately identifiable evaluation and management service by the same physician on the same day of the procedure or other service, is used when a significant E/M service is provided on the same day as a minor procedure. In this case, the E/M visit was for evaluation of the dislocated shoulder, which led to the decision to perform the reduction procedure. The E/M service was separate and significant enough to warrant reporting it in addition to the procedure. Reporting only the procedure or both codes without modifier 25 would likely lead to denial or incorrect payment. Question 9. Which section of the CPT manual contains codes for surgical procedures performed on the musculoskeletal system? A. Surgery. B. Medicine. C. Radiology. D. Pathology and laboratory. Answer: A. Surgery. This question asks about the organization of the CPT manual. The CPT manual is divided into several main sections based on the type of service. Surgical procedures, including those on the musculoskeletal system, bones, joints, muscles, are found in the surgery section. The medicine section contains codes for non-surgical services like immunizations and therapeutic procedures. Radiology contains imaging codes, and pathology and laboratory contains lab test codes. Knowing the layout of the CPT manual helps you quickly locate the correct code range. Question 10. What is the anatomical location of the olecranon? A. Knee. B. Ankle. C. Elbow. D. Shoulder. Answer: C. Elbow. This question requires basic anatomical knowledge relevant to medical coding. The olecranon is the bony prominence at the tip of the elbow, which is part of the ulna bone. Understanding anatomical landmarks is crucial for accurately selecting procedure codes, especially in the musculoskeletal section of CPT and for reporting injury diagnoses in ICD-10-CM. Knowing the location of structures like the olecranon helps ensure you are coding procedures or injuries to the correct body part. Question 11. A patient is given 500 mg of a chemotherapy drug intravenously. The drug is supplied in 100 mg vials, and the remaining 50 mg from the last vial is discarded. The HCPCS Level 2 code for the drug is JXXXX, with a descriptor indicating it is reported per 10 mg. How many units of JXXXX should be reported? A. 50. B. 500. C. 55. D. 550. Answer: A. 50. This question tests your understanding of reporting drug units using HCPCS Level 2 codes. The code is reported per 10 mg, and the patient received a total of 500 mg. To calculate the units, you divide the total dosage administered by the unit measurement of the code, 500 mg/10 mg per unit equals 50 units. The amount discarded is not reported unless specifically allowed by payer policy and reported with a modifier, but the question asks for the units administered. Always check the descriptor of the HCPCS drug code to determine the correct unit measurement for billing. Question 12. A patient is seen for management of type 2 diabetes mellitus with diabetic neuropathy. Which ICD-10 CM code should be reported? A. E11.9, G60.9. B. E11.40. C. E11.42. D. G60.9, E11.9. Answer: C. E11.42. This question focuses on coding diabetes with complications in ICD-10-CM. When diabetes is documented with a related complication, a combination code is often available and should be used. The alphabetic index under diabetes, diabetic, with neuropathy directs you to codes that link diabetes and neuropathy. Code E11.42 is the combination code for type 2 diabetes mellitus with diabetic polyneuropathy. While E11.9 is for type 2 diabetes without complications and G60.9 is for unspecified polyneuropathy, the combination code is more specific and accurately reflects the documented relationship between the two conditions. Question 13. A physician provides critical care services for 75 minutes to a critically ill patient in the intensive care unit. The physician is the only provider billing for critical care during this period. What CPT codes should be reported? A. 99291. B. 99291, 99292. C. 99292X2. D. 99291, 99292X1. Answer: D. 99291, 99292X1. This question requires knowledge of critical care coding rules. CPT code 99291 is used for the first 30 to 74 minutes of critical care on a given date. Code 99292 is an add-on code used for each additional 30 minutes beyond the first 74 minutes. For 75 minutes of critical care, you report the initial code 99291 for the first 74 minutes, and then code 99292 for the remaining time, as 75 minutes falls into the range covered by 1 unit of the add-on code when combined with the initial code. Always calculate the total critical care time carefully to determine the correct number of add-on units. Question 14. A patient presents to the emergency department with acute abdominal pain. The physician performs a comprehensive history, comprehensive examination, and high-complexity medical decision-making. What is the appropriate E/M code for the physician's services? A. 99283. B. 99284. C. 99285. D. 99291. Answer: C. 99285. This question tests your understanding of E/M coding in the emergency department setting. For emergency department visits, codes 99281 to 99285, you must meet all 3 key components, history, exam, MDM, at the level specified or exceed the requirements for the code level. The documentation states comprehensive history, comprehensive examination, and high-complexity MDM. Code 99285 requires a comprehensive history, comprehensive examination, and high-complexity MDM, matching the documentation provided. Code 99291 is for critical care. Always check if all 3 key components are met when coding emergency department visits using the 1995/1997 guidelines. Question 15. Which of the following is a CPT modifier that indicates a procedure was bilateral? A. RT. B. LT. C. -50. D. D. -26. Answer: C. -50. This question asks about the CPT modifier for bilateral procedures. Modifier -50 is appended to a surgical procedure code to indicate that the procedure was performed on both sides of the body during the same operative session. Modifiers RT and LT indicate the right and left sides, respectively, when the procedure is unilateral. Modifier -26 is for the professional component of a technical procedure. Remember that modifier -50 is generally appended to the procedure code only once, not to each side. Question 16. A patient is admitted to the hospital with pneumonia. The physician performs an initial hospital inpatient E/M service. The documentation supports a comprehensive history, comprehensive examination, and moderate complexity medical decision-making. What CPT code should be reported? A. 99,221. B. 99,222. C. 99,223. D. 99,231. Answer: B. 99222. This question involves coding initial hospital inpatient E/M services. For these services, codes 99,221 to 99,223, you must meet or exceed the requirements for all three key components, history, exam, MDM, to select the code level. The documentation specifies a comprehensive history, comprehensive examination, and moderate complexity MDM. Code 99222 requires a comprehensive history, comprehensive examination, and moderate complexity MDM, aligning perfectly with the documentation provided. Code 99231 is for subsequent hospital inpatient visits. Always ensure all three key components meet the level required for initial hospital E/M codes. Question 17. A patient is diagnosed with malignant neoplasm of the lower outer quadrant of the female right breast. The cancer has metastasized to the regional lymph nodes. What is the correct sequence of ICD-10-CM codes? A. C50.411, C77.3. B. C77.3, C50.411. C. C50.411, Z85.3. D. C50.411. Answer: A. C50.411, C77.3. This question tests your knowledge of coding malignant neoplasms and metastases in ICD-10-CM. The primary malignancy is coded first, followed by the code for the metastatic site. C50.411 is the code for malignant neoplasm of the lower outer quadrant of the right female breast, the primary site. C77.3 is the code for secondary and unspecified malignant neoplasm of axillary and upper limb lymph nodes, the metastatic site, as regional lymph nodes for the breast are typically axillary. Z85.3 is for personal history of malignant neoplasm of breast, which is not applicable for a currently active malignancy. Always sequence the primary site before the metastatic site. Question 18. A surgeon performs an excision of a benign lesion measuring 1.5 cm with a 0.5 cm margin on the patient's back. The excised diameter, including margins, is 2.5 cm. The closure was simple. What CPT code should be reported? A. 11,402. B. 11,403. C. 12,032. D. 11,603. Answer: B. 11403. This question requires you to correctly measure and code the excision of a benign lesion. CPT coding for lesion excision is based on the excised diameter, which includes the lesion plus the narrowest margin required for complete excision. The excised diameter is calculated as the lesion size plus both margins, 1.5 centimeters plus 0.5 centimeters plus 0.5 centimeters equals 2.5 centimeters. Code 11403 is for the excision of benign lesions from the trunk, excised diameter 2.1 to 3.0 centimeters. Code 11402 is for 1.1 to 2.0 centimeters. 11603 is for malignant lesions of the trunk 2.1 to 3.0 centimeters, and 12032 is for intermediate repair of the trunk. Always use the excised diameter when selecting lesion excision codes. Question 19. Which term refers to the study of the causes of diseases? A. Pathology. B. Etiology. C. Epidemiology. D. Physiology. Answer: B. Etiology. This question tests your understanding of a basic medical terminology term. Etiology is the study of the causes, origins, or reasons behind a disease or condition. Pathology is the study of the nature of disease and its causes, processes, development, and consequences. Epidemiology is the study of the distribution and determinants of health-related states or events in specified populations. Physiology is the study of the normal functions of living organisms and their parts. Knowing medical terms like etiology is essential for understanding diagnosis descriptions and selecting appropriate codes. Question 20. An explanation of benefits, EOB, from a payer shows that a service was denied because it was considered bundled. What does bundled mean in this context? A. The service is not covered by the patient's insurance plan. B. The service is included as part of a larger procedure or service that has already been reimbursed. C. The service required prior authorization which was not obtained. D. The claim was submitted with incorrect patient information. Answer: B. The service is included as part of a larger procedure or service that has already been reimbursed. This question relates to billing and payer concepts, specifically bundling. Bundling occurs when a payer considers certain services or procedures to be integral components of a more comprehensive procedure. Instead of paying for each component separately, the payment for the comprehensive procedure includes reimbursement for the bundled services. This prevents separate payment for services that are routinely performed together. A denial for bundling means the payer believes the service should not be billed separately because its payment is included in another service billed on the same claim. Question 21. A surgeon performs an appendectomy. The global surgical package for this procedure typically includes which of the following? A. The initial consultation with the patient before the surgery. B. The surgeon's preoperative evaluation and management on the day of the surgery. C. Visits related to the surgical recovery 60 days after the surgery. D. All services provided by the anesthesiologist during the surgery. Answer: B. The surgeon's preoperative evaluation and management on the day of the surgery. This question asks about the components of the global surgical package in CPT. The global surgical package includes all necessary services normally furnished by the surgeon before, during, and after the surgery. This typically includes the preoperative E/M service on the day before or day of surgery, the intraoperative service, the surgery itself, and routine postoperative care for a specific period, example 0, 10, or 90 days depending on the procedure. The initial consultation before the decision for surgery, visits unrelated to the surgical recovery, and services provided by other physicians, like anesthesiologists, are generally not included in the surgeon's global package. Question 22. A patient presents with pain in the lower back radiating down the left leg. The physician suspects lumbar radiculopathy. Which anatomical region is primarily involved? A. Cervical spine. B. Thoracic spine. C. Lumbar spine. D. Sacral spine. Answer: C. Lumbar spine. This question tests your understanding of anatomical regions related to common medical conditions. Radiculopathy refers to pain or dysfunction caused by compression or irritation of a nerve root. Pain radiating down the leg from the lower back is a classic symptom of lumbar radiculopathy, indicating involvement of nerve roots originating from the lumbar portion of the spine. Cervical radiculopathy typically involves the neck and arms, thoracic radiculopathy the mid-back, and sacral radiculopathy the lower spine and possibly legs, but lower back radiating down the left leg strongly points to the lumbar region. Question 23. A patient is undergoing chemotherapy for metastatic colon cancer. During a chemotherapy administration session, the patient experiences nausea and vomiting, which the physician manages. How should the management of the nausea and vomiting be coded? A. Report a separate E/M code for the management of nausea and vomiting. B. The management of side effects like nausea and vomiting is typically included in the chemotherapy administration code. C. Report a separate procedure code for the management of nausea and vomiting. D. Report an ICD-10-CM code for the nausea and vomiting as the primary diagnosis. Answer: B. The management of side effects like nausea and vomiting is typically included in the chemotherapy administration code. This question addresses the coding of side effects during chemotherapy administration. Routine management of temporary, self-limiting side effects or complications that arise during and are related to the administration of chemotherapy, like nausea and vomiting, is considered part of the chemotherapy administration service and is not separately reportable. An E/M service would only be separately billable if significant, separately identifiable work was performed beyond the typical pre- and post-administration assessment and monitoring. Code the nausea and vomiting, R11.2, as a secondary diagnosis to explain the patient's symptoms, but the management itself is usually included in the administration code. Question 24. A patient is diagnosed with acute bronchitis due to respiratory syncytial virus, RSV. What is the correct ICD-10-CM code? A. J20.9. B. J20.5. C. B97.4. D. J20.9, B97.4. Answer: B. J20.5. This question requires you to find the specific ICD-10-CM code for acute bronchitis caused by a specific infectious agent. The alphabetic index under bronchitis, acute, due to, RSV, respiratory syncytial virus, directs you to code J20.5. Code J20.9 is for acute bronchitis, unspecified. While B97.4 is the code for respiratory syncytial virus as the cause of diseases classified elsewhere, the coding guidelines for infectious diseases typically state to use a combination code that identifies both the infection and the organism, if available. J20.5 is that combination code. Question 25. According to CPT guidelines, what does the symbol plus next to a code indicate? A. The code is new for the current year. B. The code is an add-on code and must be reported with a primary procedure code. C. The code description has been revised. D. The code is a resequenced code. Answer: B. The code is an add-on code and must be reported with a primary procedure code. This question tests your understanding of symbols used in the CPT manual. The plus symbol identifies add-on codes. Add-on codes describe procedures that are performed in addition to a primary procedure and are never reported alone. They are typically listed after the primary code they should be reported with. Other symbols in CPT include a bullet point, new code, a triangle, revised code description, and a lightning bolt, resequenced code. Familiarizing yourself with these symbols is important for accurate code selection.